This is a very, very important meeting for the transplant program. It is required by the people who pay us the money, by CMS, by UNOS, and by the state to provide this multidisciplinary training every year so that everybody's on the same page with transplantation. As you know, our transplant program is the only program serving a very large population, even though our transplant rates haven't met there yet, but they'll get there. But we are the largest in terms of serving a population. Brooklyn has 2.6 million people. Staten Island has about nearly 700,000 people. Queens has 1.8 or so million people. And that is the population that we're serving. And we get some catchment also from Long Island. And then we have people coming from the Caribbean. So if you look at the population that we serve, it's actually the largest in terms of service in New York City. So that's how you have to think. We're located in a place where this transplant program can flourish. It can actually be the dominant player in transplantation for kidneys in New York City. It did that before. We call that the old glories. The old glories are just to think about, but we, as a team, we have to create new glories, right? Wherever we are right now, you have to be part of the team that creates the new downstate, the new transplant program. Not that 10 years ago we're like this, and then 20 years ago we're like that. Okay, that is fine. Somebody did that. What about us? All right, we have to create new glories. And until we create new glories, we cannot move the transplant program or any other program forward. So that is my message to you. Let's all work together. Let's all plan together. Let's all have the same mission in mind. A mission that is dedicated to service excellence for people with kidney failure who are coming for a kidney transplant. Now, for now, I know you are all doing it. Everybody's geared up. If you look at the Press Ganey surveys, right? The transplant program always has the best surveys in the hospital. So let's give ourselves. Okay, it always has. If you look at it for the last maybe 6-7 years. Every year, the transplant program is at the top of the Press Ganey surveys. So you're already doing a fantastic job, right? Which is very good. All I'm saying is let's capitalize on that. Let's create some new glories, and let's make sure that the people who are coming here to get a transplant would spread the word that this is the only place to come for a kidney transplant. So that is the message for me. Now, the message that I have, which is more personal, has to do with our new chair. No more new, but our new chair, Dr. Gruzna. Dr. Gruzna is coming. It's very rare, by the way. Just you can, after I say what I'm saying, just Google and see what I'm saying. It is very rare to have a chair of surgery who is also a transplanter. That combination is very, very rare. Do we have it in New York City?
No, actually it's becoming rarer because the chairs at UCSF and UCLA, that were some of the biggest programs in the country, are stepping down or have stepped down. So there are maybe three in total now.
That's it. That's it. All right? So, you see, we don't know these things. I want you to be proud of that. When you have a chair who's also a transplant surgeon, that means that you have access. Like vascular access for dialysis, you have access. If you want to build a transplant program, you cannot build it under that circumstance, then you are missing opportunity. So for that reason, I think we're lucky to have Dr. Gruzna, and I know that Dr. John has built a very viable, high-quality transplant program. So with that combination, we should be seeing ourselves doing a whole lot of transplants, 100 or more transplants in the near term. So thank you to Dr. John for creating all these policies and procedures. He's big in quality. We understand that, and I think that with the quality mindset and with the volume mindset that we're trying to bring, if you mirror the two of them, quality and volume, we are really going to be the best in New York City. So again, you are in the best possible state to run the program. You have all the things you need. If there is anything that I can help from the medical side, I'll be happy to. Myself and Gruzna, we have exact same plan, right? Between us, we have exact same plan. If you talk to him, and then you close the door and you talk to me, you see that the language is the same. That's how much we are synchronized. And we want everybody to feel the same way. We want everybody who's working to create a system to think the same way, because at the end of the day, we are here to serve. I'm going to be retired or be fired. Somebody's going to be retired or fired, and the system has to keep moving. So the system should not be depending on people. It should be depending on quality decisions. The system should be dependent on quality decisions by the people who are leading it, so that there is continuity, there is sustainability. So that's what we intend to do. We don't have any agenda other than to do good. No agenda. We are not here to, create agendas. We're just doing good. So because of that alignment, medicine and surgery, I think if we can continue to work together the same way like we're working in transplant, this hospital would come up out of its problems that you all know about. So thank you again. Enjoy the conference. And I'll be in and out of, I have another one going on in oncology. I'm going in and out. But enjoy the conference, and thank you all for coming this morning. I'll go in and I'll come out.
Yeah. Good morning. It was a driving nuts, I know. But what I wanted to do before I have a formal lecture, what I wanted to do is because we were a small group, and I thought the room would not be big enough for us, and we would have to go to the main auditorium, and we don't have to. I thought we introduce ourselves briefly, because you probably know we know probably most of each other, but nevertheless, why don't we go ahead?
Good morning, Andrew D'Onofrio from Transplant Laboratory.
Okay.
Mm-hmm. Very Fontenelle, outreach liaison for transplant.
Susan Sanders, outpatient transplant.
Victor Ocasio, data manager for transplant. Kevin John, transplant.
Kevin John.
Civil scientist.
Cathedra transplant nephrology.
Good. So, first of all, thanks. For all the ones that are here.
Everybody knows me. That's
Well, Carrie, everyone knows her. I'll give her credit in a second anyway. It's great that you're all here. Obviously, transplantation is much more. So, many people are not here for whatever the reasons are. But I think it's great that you came, because in order to, it does take quite a bit of organization to put a program like this one together. And Carrie, I must say, did a great job in putting the topics together. And I'll just briefly go through them and tell you why I think they are important. Muriel Briggs, is she coming?
Ms. Briggs is out. Ms. Easy is going to be giving the
Okay, good. So the waitlist management and evaluation is important, because as you know, UNOS grades and flags programs by performance. So you all know that, two of the hard criteria are 1 year graft survival and 1 year patient survival. So what UNOS does is it bases the individual center's outcome on what would be expected the entire country versus what is observed. So we are observed, and our observed number, that's actually the one that we create, is compared to what is expected. And using a bunch of statistical methods, they will let us know whether we are within that framework. If you're not within the framework, UNOS can hold the program or can actually put you out of business. So quality, that's what Dr. Salifu said, is extremely important. There's another measure that is important, that is how many of the patients are transplanted off the list. Traditionally, with everything that happened about 10 years ago, the numbers have gone slowly up, and we're slowly catching up with the number of patients transplanted off the waiting list. But we are not there yet. I mean, there we usually get a red flag, but we have made progress in that regard. But it's very important to understand, I mean, the wait list, the criteria, what it means in terms of outcome, and what direction we are going. Carrie is going to talk about the UNOS allocation and the new criteria that have been put in place. You can imagine an organization like UNOS trying to put rules into place. It's like Capitol Hill talking about tax reform. There are lobbyists coming out of each corner, and everyone wants to do and have the best for his or her interest group. There are the people that are fighting for patients with polycystic kidney disease, and that's the only thing that they care about. Then there are patients out there that fight for diabetes. Then there are the pediatricians. You know, everyone knows, I mean, kids are really, really important. So, I mean, the allocation is done in such a way that children clearly are advantaged over, let's say, older adults. But once a rule is spelled out and goes out for what they call for public comment, I mean, there are I mean, hundreds and hundreds of emails from all kinds of interest groups that try to push, I mean, their cause. That is true for all organs. It's particularly true for the kidney because most transplants, as you know, are kidney transplants. It is much more ferocious when it comes to liver transplantation because the liver is a life-saving organ in contrast to the kidney. Kidney fails, what you do, you go back on dialysis. If you don't get a liver, you are dead. So that's why these comments are very important, and UNOS invites everyone, particularly from the transplant community, to comment on whatever the new allocation policy is going to be. Carrie is going to talk about the new kidney allocation policy. I remember that in 2002, we started talking about a new allocation policy. It took over a decade to get to where we are. And even the new allocation policy, I mean, as always, is not perfect. Carrie also is now member of the MPSC committee within UNOS, which is the most powerful of all programs, the Membership and Professional Standard Committee, that really looks into the failings and deficits of each single organ across the country. They have the power to penalize individual surgeons, but also to penalize complete programs. So a lot of the press that we have been hearing about transplantation, aside from, I mean, all the great news in the 80s, 90s, and so forth, about buying organs, having people go to other countries, buy organs there, then come back and expect us, all of us, the taxpayer, to pay for, I mean, some of these transplants that were done, maybe to them in good faith, but poorly executed, they come back. Those are all issues that UNOS and the MPSC is dealing with. So allocation, UNOS, MPSC is important. HLA and cross-matching consideration. When I started, there was only one technique to do cross-matches. It's completely changed. DSAs, we take that for granted. DSAs are donor-specific antibodies, meaning the body, after a transplant, generates either pre-existing antibodies, despite the fact that you're immunosuppression, and these antibodies, if you're dealing with autoimmune disease, will attack the organ, the newly transplanted organ, as was done with a native organ, or new antibodies that are generated anew. We had no clue in the 80s and 90s that, I mean, there were antibodies that could cause damage to the organs. So a lot has happened with regard to HLA matching. All we knew back then was that there were groups of antigens that were considered to be related to each other and that might have been advantageous with regard to transplantation. But that really was all that we knew at the time. Back then, because we didn't have good immunosuppression, matching was very important. And I'm primarily talking to the nursing staff now because you're taking care of all these patients, but I think it's also important for you, to understand the background where we're coming from and where we are going. But at the time, we didn't have the immunosuppression that you are now familiar with and that you are administering to the patient, whether it's Prograf or Cellcept or whatever it is. So in order to have good outcome, what we had to do is we had to match the donor with the recipient. And we know since the 1960s that there are what we call 6 antigens that are important for the matching process. HLA-A, HLA-B, HLA-DR. There are more, but those are the 6 big ones. And we have 2 of them. And they're inherited, one from the paternal, from the maternal side. There are 6 antigens. So that's why we call a 6 antigen match an identical match. And we want to make sure that these patients actually are the ones that have the best results. Because if you go back to, the first successful kidney transplant in the 1954 that was done in Boston by Joe Murray, who later received the Nobel Prize for it. That was not the first kidney transplant in the world. It was the first successful transplant. It was the first successful transplant because it was done between identical twins. At the time, no one had an idea about immunosuppression. Even steroids, the use of steroids in transplantation was not standard. People were talking about maybe using steroids, but no one had a clue. Azathioprine, Imuran, that we're not using anymore, or by and large not using anymore, did not come about until the 1960s. Cyclosporin, not until the 1980s. Prograf, not until the 1990s. Same for Cellcept. So early on, all that we could do were transplants between identical twins with good outcome. And that's what Joe Murray showed, and for which he got the Nobel Prize. The interesting thing is he didn't stay in transplantation despite being so successful there. He was the chief of plastic surgery and reconstructive surgery at Harvard until basically he retired from Harvard. So Dr. Noren is going to talk about HLA and cross-matching. Dr. Asagi, one of our initially non-transplant nephrologists, now is really part of the team, and he was gracious enough to go to Wisconsin to learn about pancreas transplantation, which is a completely new field, and I'll talk about that in a few minutes. But he will really give you an idea the similarities between kidney and pancreas transplantation and the differences. Pancreas transplantation is a complete different animal. When we do a kidney transplant, we hardly see surgical complications. Maybe 1 or 2% of all kidney transplants fail because of blood clots, leakages, or whatever. Liver transplantation is different. The fate of the patient is decided or determined when the patient is on the operating table. It is not uncommon, even in experienced hands, to lose a patient on the table. In its extremes, patient may require 100, 200 units of blood during the procedure. This is a completely different animal, and we are currently not equipped, to do liver transplants. But if we want to be a serious academic center at some point, liver transplantation, heart transplantation has to be part of it, because we need to train our staff, our nursing staff, we need to train our medical students, we need to train our residents. And not everyone will find a job at a place where they don't do liver or heart transplants. But if you apply at places where they do them and you don't have that experience, you are disadvantaged right from the get-go. So that's why it's important long-term to get back to these transplants that used to be done, small numbers in the 1990s, but since then have not been performed anymore. Pancreas transplantation is completely different than the other two, kidney and liver transplantation. Unlike liver transplantation, we usually do not lose patients on the table, very rare. But unlike kidney transplantation, it is much more complicated when it comes to surgical complications. If you are a pancreas transplant surgeon, you have to be not only a transplanter, but you have to be a solid general surgeon and a vascular surgeon, because the anatomy is such that it is much more complex than the kidney is, in many ways also than the liver is. The pancreas is attached to the duodenum, so you have gastrointestinal involvement. The reconstruction of the blood vessels is very different from the liver and the kidney because it takes us 2 hours on the back table to do the bench preparation. It's a low flow organ with a high thrombosis rate. We are dealing with pancreatitis. Most of you on the nursing side, you're familiar with patients with chronic pancreatitis and acute pancreatitis, what it can do. The ones of you that have been dealing with patients that have pancreatic cancer, you know what treacherous organ the pancreas is. When the first pancreas transplant was done, people really asked the wisdom about even embarking on it. So it's a very, very different animal in that regard. And Dr. Sagi will talk about his experience in Wisconsin. And it has changed dramatically. He will talk about that because he was involved in the pancreas transplant programs, both the University of Texas and then at Mount Sinai some 20, 25 years ago when the results were really poor. And I mean, this has changed and evolved like no other transplant field over the last 20 years or so. You know, this always happens shortly before they have the flood here. So, I mean, that's just the first indicator that a flood will be coming. I'm kidding, guys. I'm kidding. You have to be careful what I'm saying. Dr. John will talk about the surgical aspects primarily of the kidney transplant that you guys are familiar with. Then we will talk about the immunosuppressive medications. I want to say a couple of things there. The mainstay immunosuppression that we know are Prograf, Cellcept, and steroids. And then we have, and these are used for maintenance therapy. So maintenance therapy, the word maintenance therapy means the patient will be maintained on that medication for the rest of his or her life, as far as we know now. Tolerance, meaning living without any form of immunosuppression, is the holy grail of medicine. If we achieve tolerance in transplantation, we will also be able to achieve tolerance in autoimmunity, and we will cure a whole barrage of diseases. But we are not there yet. So as of today, patients need to take immunosuppression, with few exceptions, identical twins that I mentioned before. But another field has evolved in a way that was not anticipated. I just mentioned maintenance therapy. The other component is what we call induction therapy. Induction therapy is what you give initially for the first few days to your patients so that they do not reject. It's a thymoglobulin that you guys are familiar with. We use thymoglobulin. The Europeans and Chinese use red ATG. I'm not sure if we are now imposing tariffs on red ATG if we introduce it to us, or whether they are going to put tariffs on our thymoglobulin. But the bottom line is, I mean, those are the two medications that are primarily used. But aside from that, a complete new field of new antibodies have evolved. And they have evolved in part because we also have a different understanding than what we had 20, 30 years ago about rejection. When we trained, we knew two forms of rejection: acute rejection and chronic rejection. Acute rejection you can treat, and you can treat successfully. Chronic rejection are changes that are, wow.
Good job.
So the third floor is flooded. So we have acute and chronic rejection. Acute rejection we can treat. Chronic rejection we cannot treat. All we can do is just help a patient to continue, and then at some point release the patient. With an acute rejection, we now have two forms that we didn't know at the time. The first one is acute cellular rejection, which always has been known, and you see lymphocytes, the subgroup of the white blood cells, infiltrating the grafts. But then we have also antibody-mediated rejection. Antibody-mediated rejection goes back to what I said before. The body can generate de novo or pre-existing antibodies at a relatively high rate after transplantation. So if you have antibody-mediated rejection, the graft is primarily damaged by the antibodies, not so much by the cells. And then there's a combination of both, acute cellular and antibody-mediated rejection. But the treatment for cellular rejection and antibody-mediated rejection is very different. For cellular rejection, we usually give either steroids according to the grading of the rejection episode, and that was determined about 15, 20 years ago, a small place in Canada, Banff, the Banff criteria, which tell us what kind of rejection episode you are dealing with, and by and large it's mild, moderate, severe, but they have a much more sophisticated classification these days. And if you have mild and moderate rejection, kidney rejection, you usually give steroids. If you have severe rejection, particularly with the vascular component, then you give the antibodies. With acute mediated rejection, it is different. Antibodies and steroid won't do a whole lot. What you have to do is you have to get rid of the culprits. And the culprits are the antibodies. So how do you do that? And again, you guys are on the stations, plasmapheresis and IVIG. However, we have also learned that both plasmapheresis and IVIG may not be strong enough to get rid of these antibodies. So a whole slur of new antibodies are coming out and are on the market. Bortezomib, eculizumab, alemtuzumab, those are all medications, all antibodies that interfere with different systems and different cells in the body that we had no clue about, just a few years ago. Some of them even have an impact on the complement system. The complement system is important with regards to antibody-mediated rejection because what it does is it can cause thrombosis within the graft and so forth. So over the next 5 to 10 years, you will see a change the way we are treating our patients with newer and probably better medications coming on board. The same like Imuran and Cellcept. Cellcept is kind of the successor to Imuran. We hardly ever use Imuran anymore. There have to be certain reasons why we do it. Because Cellcept is so much more specific. Imuran had many more side effects than Cellcept has. And the same is going to happen with some of these very, very specific antibodies. And very often, when you watch TV, you sometimes hear about antibodies that you can't even pronounce the name because people have become so creative and the names of these antibodies are getting longer and longer. But that's what's coming down the pipeline. So I think an understanding of the immunosuppression is important, and I think having pharmacists here talk about these things is crucial. Discharge planning. So for transplants, we are not reimbursed, or the hospital is not reimbursed by service. So let's say the patient is in the ICU for 7 days. We cannot charge 7 days in the ICU. We are reimbursed by DRG, which means we get a global rate for a kidney transplant. Now, I won't ask the question again because I did that last time when I gave a talk, but on average, Medicare and Medicaid, they pay anywhere between $60,000 to $70,000. You may think that is a lot. It actually is not. Because what it all includes is, the patient coming to the hospital, being prepared for the operating room, the actual procedure in the operating room, the hospital stay later in the intensive care unit, the medications, and everything else that may happen, including complications. So we have to take the patient back for surgery or something else happens. It's all part of your package. And 3 months of follow-up. So, in fact, we, the richest nation on the planet, are not even paying immunosuppression for the patient that receive transplants for life. So some of our patients lose their grafts not because they are non-compliant, but they cannot afford buying medication. For many of them, it's either buy medication or you buy food. That's how dire it is. I always keep saying Brooklyn is the poor sibling of Manhattan. We have people here that live in utter poverty and that need a transplant to survive. And it goes fine as long as the medication is paid. And then after that, once there is no more support, financial support, patients are faced with a question, I mean, do you want to eat or do you want to have your drugs? And many people just have to let go. So what is important is the patient that we have. Well, let me say two things. When I came here, I had no clue about Brooklyn, the people, infrastructure, and so forth. I must say I have worked at different public universities before in Minnesota and Arizona. I have rarely seen patients as grateful as patients here in Brooklyn. And I tell you why. Many of these patients have no way to go someplace else. You know, many of the poor, underprivileged will not be accepted. At, let me just see. Hey, Carlos, can I call you back in a minute? I'm just giving a talk. Okay, bye. Goodbye. Sorry, guys. The patient that we see here, I mean, we are it, the nursing staff, the physicians, because these patients cannot go and will not go to Columbia, to the Mayo Clinic or to the Cleveland Clinic because they don't have the financial means. You know, I mean, unfortunately, medicine in that regard is ruthless. It's not decided at your level or at our level. It's decided by someone who sits at the reception and looks at the insurance card. And if there is no coverage, that's it. You know, I mean, this is the greatest country on the planet, as I said, and we are still not taking care of the ones, I mean, who, for what reason ever, are not doing well. And we always have to remember the reason why we are here and why we are enjoying all of this is because we are healthy and you are willing to work. But if suddenly a catastrophe happens and you become sick, you might find yourself on the other side. So that's why it's so important to understand that, I mean, we as a society have a responsibility to take care of the ones that can't anymore. And as I said, I mean, I'm frequently moved when I talk to patients here who tell me about, I mean, their day-to-day quarrel fights and their plain survival. So I think we're very privileged in that regard to have a patient population that is very grateful to what we are doing. And I mean, that's really the way it should be. But what is also important, what I wanted to say is that because we have these types of patients, we also see patients that are much sicker than patients that are seen Cleveland, Mayo Clinic, and so forth. We are also advantaged by the diversity that we have. There is probably not a single ethnicity in the world that is not in some form represented in Brooklyn. And I think, I mean, this is what makes us great and strong. Because we learn so much from each other. I mean, if we listen to each other and once we get to know, I mean, the cultures and so forth. But with that also come diseases that are much rarer than, I mean, in other places. Minnesota, I mean, you've got a bunch of Scandinavians and Germans there, and you know exactly what kind of diseases you are dealing with. It's a very homogeneous group. Here, you never know, I mean, what the background is, and what potential diseases, I mean, might, I mean, be involved on top of what you're currently dealing with. So I mean, the spectrum of diseases here is very, very different. But what that also means is that our patients are more complicated than, let's say, a straightforward patient who loses kidney function because of glomerulonephritis or so. Our patients very often have other issues, other autoimmune diseases, and so forth. And that also translates then into longer hospital stay. But what does longer hospital stay mean if you get a certain amount of money? It means the hospital doesn't make money on it. When you talk to our administrators and the financial administrators, they will tell you, oh, transplant loses money. And you ask yourself, hold a second. I mean, a third of this hospital lives from transplantation and from transplant patients. The reason is $60,000 is not a whole lot if you have a complicated patient who has to stay in Gemma's ICU for 7 days. Okay? You know, I mean, 7 days of ICU itself is, at least on paper, a charge of close to $100,000. So in order to make money on $60,000, the patient has to go home within 4 days. How many of you have seen patients go home within 4 days? It's the exception. I'm not saying it doesn't happen, but it's the exception. The patient is complicated. You have to bring him back to the ICU, to the ICU or back to the OR. And then, of course, it's very, very different. Now, kidney transplantation rarely exceeds $1 million. Liver transplantation, very different, or multi-organ transplantation. There are only 2 centers now that are doing multi-organ transplants in New York. That is Mount Sinai and Columbia. But easily $1 million, $2 million, $3 million, because these are very, very complicated cases. And only organizations with deep pockets can afford doing that. Now, that's why it's so important that there is a strong relationship between the people that negotiate the contracts with insurance provider and with medical and nursing staff. How many of you have been asked to sit on the table about contract negotiations? I'm not surprised. Unfortunately, that happens primarily at institutions that are savvy when it comes to entrepreneurship, because they want to make money. So they involve their nursing leadership or the medical leadership. Other institutions don't do that. And then they end up with a reimbursement of $60,000 and no carve-outs. So carve-outs are meant for those patients that have complications or bad complications. So let's say you have a patient who needs a kidney transplant, but also is diagnosed right after the kidney transplant with leukemia. Let's take a really weird example. And the patient then suddenly needs to go on medication that are harmful to the kidney stay is prolonged and so forth. We still might get only $60,000 because the second disease was diagnosed while the patient had the kidney transplant. And the hospital bill is, let's say, $500,000 or $1 million. So we have to have carve-outs for those people that are outliers. So if you have outliers and they are well-defined and you have carve-outs, then the institution is protected. And with many insurance companies, unfortunately, don't have that. But getting back to what I said before, discharge planning and making sure that the post-operative process is streamlined to a way that these patients don't stay for too long in the hospital is crucial. It's crucial for the hospital, and it's crucial for the hospital in terms of turning around and saying, hey, you guys are not bringing in money from transplantation, despite the fact that you're all working very hard and all you're doing is taking care of patients day in and day out. But I mean, keep that in mind. I mean, it's very important that we do that. The other thing is there are certain cutout times when a patient has to leave. Let's say the cutout time is noon. 5 minutes after noon, an entire new day starts. So then the patient is not in the hospital for 4, but suddenly for 5 days. Again, the profit margin for the hospital goes down. That's why I keep telling my residents, you have to discharge patients at a certain time, and you have to make preparations before. Now, at least a day or 2 days before. Now, in transplantation, it's even more important that we plan accordingly. And because we are thin spread, Kerry doesn't have, 10 social workers or 5 pharmacists or whatever, or people doing other things that are important. But what we need to do is basically starting on day 3, we have to have that entire machine going. Other institutions, the second day is when they start educating the patients, because sometimes that is the holdup. And then if, let's say, education is not possible over the weekend, well, what that means is you add 2 days to the discharge. So 2 days more of financial losses. I'm not telling you that for whatever reasons. I'm telling you that because I think it's important to understand how this world unfortunately works now. Transplantation has become a business, and a big financial business for many institutions. Some institutions do well, others don't do well. We have to make sure that we are on the side of the well-doers, because otherwise we cannot expand transplantation services. So discharge planning, as I said, is important, and that's also where the nursing staff comes into play. I mean, ultimately what we need to do is basically 1 or 2 days, preferably 2 days before the anticipated discharge, the physician should sit down, including someone from nursing staff on the floor, 82 or wherever the patient is, and go over all the issues and the problems that this patient may be facing after discharge or at the time of discharge, to make sure, I mean, it's planned. Not that you guys are on rounds with the physician in the morning, oh, patient XYZ can leave in half an hour. Well, I mean, you know, it's not going to happen in half an hour anyway. But you also need time to plan for it. So we have to do a better job in that regard to integrate the nursing and the medical services. Long-term care of a kidney transplant patient. Dr. Brar is going to talk about that. That is also a very important issue. We are doing okay when it comes to 1-year patient and graft survival because we meet the UNOS expectations. We don't do well long-term. Our 3, 5, and 10-year graft and patient survival rates, if these were hard criteria, they would flag us to the point that they're saying, I mean, you are way below the national average. That has many factors that come into play. One of them I already mentioned. Some of our patients cannot afford buying the medications after the transplant. And they lose their graft. They don't lose it immediately, usually not immediately, but they will use it over 3, 6, 12 months. That is one of the reasons. The second reason is that we do not, and we are not equipped to a follow-up that is even closer than what we are currently doing. And that has something to do with the limited infrastructure that exists. The coordinators that we have is a relatively small number compared to other programs. Social worker, we don't have enough. Pharmacy, we don't have a transplant-dedicated pharmacist. The list goes on and on and on and on. But that's the reason why we're not doing well there. What that also means is that our patients have a higher retransplantation rate. Higher retransplantation also means unless you have carve-outs, you're going to lose money on them because if they pay you only $60,000 for the retransplant, despite the fact that it's more complicated and so forth, we're again losing money on it. So you see there is a vicious cycle once it starts. And there are many ways where we can interfere and make it better. But that has to come ultimately from the top of the administration to support people here. But the long-term kidney transplant care is important because we have made a lot of progress within the first year. 10 years ago, the half-life of a deceased donor kidney, make it 15 years ago, the half-life of a kidney transplant, meaning 50% function. 50% don't make it to that number, 50% go beyond that number, was 8.5 years. This is still the number we are dealing with today. So we have not really made progress when it comes to really long-term outcome. We have made some incremental progress, but not to the same way as the 1-year graft survival went up from whatever 87% to now 93 or 94%. And that is a big problem. Dr. Sagi is going to talk then about long-term care of pancreas transplant patients. There is no doubt that the number of patients that have now excelled or have enjoyed graft function for more than 10 years, between 500,000 and 700,000 transplants have been done altogether since the inception of UNOS. And we have over 100,000 patients that have enjoyed graft function for more than 10 years. There are patients out that have had graft function for 40 years, 30 years, 20 years. So it can happen. But as I keep telling the patients, it's all about maintenance. It's like buying a beautiful old car. You know, it only runs if you put a lot of service and maintenance in that car. The other thing is sometimes I hear, oh, the donor was already 60 years old. The life expectancy of a kidney or a liver is 120, 130 years. We don't die because, the kidney gives up on us or the liver gives up on us. We die because of this here and that here. So, I mean, if you get a good kidney from a 60-year-old with a creatinine of 0.8, that kidney still has a life expectancy of 40, 50 years, you know, and that's, I mean, plenty for most of the patients that we transplant. Non-adherence and other psychosocial considerations. Now, let me make it absolutely clear. People that do not comply with the transplant staff, with the coordinators, don't take their medications, don't come in for follow-ups, and then lose their graft, have no right to demand another transplant. If we had transplants sitting on trees and we could just pick them, it would be very easy. But for every transplant that we do, we have to remember someone else who is not going to be transplanted may die. So yes, you got your chance, but you better adhere to what the coordinator, the physicians are telling you. Because if not, I mean, we will not transplant you again. I mean, this is kind of almost a social contract, and we cannot afford doing that. There are people out there that think, well, I mean, this one is gone, I'll get the next one. No, it doesn't work that way. If you can show that you lost it for good reasons, and I mean, was not your doing, of course you will get it. But if you can show that, and we know that you did not comply, or you're an alcoholic, and again you're an alcoholic after having a liver transplant, you know, no, you won't get it, because if you get it, someone else will die because you got that transplant. So people have to understand that, I mean, there's responsibility for what we are doing. You know, I mean, this is what we are offering to patients with end-stage organ failure is our service to society. We want to help people, but they have to understand if they don't follow the rules, I mean, there is no more transplant. Regulatory oversight of transplant, and I'm sure Carrie will have covered probably quite a bit by the time she's going to talk about that from her previous talk. Then we talk about pediatric transplants. Now, that is a little bit a thorn in my eye because I was always used to doing pediatric transplants, and we're not doing it here yet. We have to build the infrastructure to do even the small ones. I have done transplants in children as small as 3-month-old or 4 or 5 kilograms. There's no reason why these kids should have to go to other places. Look, Brooklyn would probably be the 6th or 7th largest city in the country if it were freestanding, you know, 3 million population. We do not have a children's hospital in all of Brooklyn. We do not have a transplant program for children. So I think we have to work on that with our friends from nephrology and pediatrics to make it happen. Because ultimately, I mean, we owe it to our community here. So for many people using battery tunnel or any of the other tolled ways into Manhattan, they can't afford it. You know, where are they going? And then the mother has a job, there's no dad or vice versa, and then they should drive over to Columbia and be seen by a nephrologist. Well, that's an entire day adventure. Many people cannot take time off for an entire day. So we in Brooklyn have to have something where these patients are going to. Then living donation, that is probably dearest to my heart. Out of all the things that I have done in my career, the one thing I am the proudest of is that I have done living donor transplants of all organs. That is kidney, liver, but I've also done living donor transplant for pancreas and intestines. And I have done it in children, and I have done it in adults, and I have done it in combination. I have done combined living donor, kidney and pancreas transplants, and combined intestinal and liver transplants. With a sad event 10 years ago, everything broke down. By nowadays standards, if I had been here, if Dr. John had been here, we probably would have handled it differently from institutional level, because this was not the first and only donor death that occurred in the country. We always have to keep in mind that the death risk of donating a kidney is about 1 in 8,000. So 1 of 8,000 donors will die. Usually it happens, like in our case, because a clip comes off and the patient exsanguates, and only can
can be diagnosed, only if it's diagnosed quickly, there's a chance of survival. What we have now seen is with the introduction of laparoscopic and robotic techniques, and not doing it openly anymore, is another form of a complication that has caused donor death. And that is an injury to the bowel, which is very, very rare. So if a patient in the morning wakes up and complains about excruciating abdominal pain, and you're taking care of that patient, don't think, oh, this is just normal. Tell the resident, you have to come, or the attending, you have to come and look at the patient, because it always can be a bowel perforation. That's the second most common reason why patients die after donating a kidney. When it comes to liver transplantation, very, very different. You remove the right lobe, that is 60% of the liver, or the left lobe, that is 45% of the liver. The risk of dying is between 1 in 400 and 1 in 500. So it is very, very different than kidney transplantation. I tell you a funny story. Sometimes you deal with somewhat with strange characters. When I was in Minnesota and had just started the living donor liver transplant program, one day I was walking down the hallway and my secretary came out and showed me I shouldn't come to the office. Well, of course I came to the office, and there was a guy who wanted to donate to the very person who had shot Martin Luther King, Ray or whatever his name was. And he wanted to donate a portion of the liver to that guy. So I told him, oh, that's great. Your risk of death when we do that is about 1 in 200. Never saw the guy again. First of all, for many reasons, that would have never been an option. But, you just put in perspective. But even at experienced centers, and some of you may know what happened at Mount Sinai with Dr. Miller, who really is a good friend, and he is a pioneer in living donor liver transplantation. It almost destroyed his career, and it put a huge, huge stain on Mount Sinai for a while. Over time, things are forgotten and so forth, but it was a big, big issue. But what it also did is at the time, the number of liver transplants in the country had gone up in the 500 range. And after that, it plummeted. And still today, we are doing only about 400 living donor liver transplants a year. There's one center in Asia, in South Korea, in Seoul. 1 year, they do between 400 and 500 of these liver transplants. They do as many as we, as an entire nation of 300 million, does. Why are they doing it? Because they don't have the deceased donor laws in place as we do. And from a cultural perspective, they are not willing to give up organs, for example. And they are very reluctant for these religious reasons to do it. When I was in Arizona, I was exposed for the first time dealing with a very different perception of living donation and transplantation compared to mainstay America. Because in Arizona, there is a large proportion of native Indians. And every Indian tribe, the Apaches, the Comanches, the Hopis, the Navajos, the Odonototems, and the list goes on, have different rules. So for some, you could add an organ, like you could do a kidney transplant. That was fine. For many of the tribes, you could not do a transplant where the organ was taken out and replaced. So replacement was not an option. There were tribes, however, that would allow it, but they insisted on that the organ that was removed was given back to the recipient. So if he or she dies, he would die as a complete human being, and then the liver or the heart or whatever was taken out would be buried with the patient. So, the customs are very, very different, even within our nation. But in Asia, the only way for someone with end-stage liver failure to survive is a living donor. Now there it's even more peculiar. with a number of friends, I edited a book on living organ donation. And one of the chapters that was in 2005, 2006, one of the chapters that we had in there was living donor liver retransplantation. So first of all, liver transplant, as you know, is a difficult procedure. Doing a living donor liver is probably even more difficult. But then a retransplant, I thought, well, I mean, maybe they have 1 or 2 cases. So I got this paperback, and they wrote about 200 cases. And I called the other editor up and said, you know, we have to talk to them. Didn't understand the title of what they were doing. I mean, this is about retransplantation and not about a first transplant. Well, as it turned out, I mean, they had done 200 retransplants. And they had done liver transplants in large people where they needed 2 donors. So they took the left lobe from one donor in one room and the right lobe from another donor in the other room. And then in the third room was the recipient, and he would get both organs. Almost impossible to orchestrate something like that here. Always remember, when it comes to donor and a recipient, the mortality rate or risk is 200%, because both, if things really go bad, both can die. So, I mean, if you have 3, I mean, potentially, I mean, you could deal with 3 patients that are not doing well. But, I mean, that's always something that we have to keep in mind. Living donation is probably the ultimate gift that anyone can give to someone. But aside from the guy who wanted to donate to, I mean, the murderer of Martin Luther King, there's another funny story. So a guy donates a pancreas and a kidney to his wife, and very jubilant about the whole thing. Outcome is fine and so forth. So half a year later, he comes back, and I see him in clinic, and he says, Dr. Grissner, I hear you can donate to unrelated people. I said, yes, you can. He says, well, I want to be such a good Samaritan. I said, well, what do you have in mind? He said, well, I want to donate part of my liver. I looked at him, I mean, really a little bit bedazzled, and I mean, why would you want to do that? Well, then I talked to his wife, and she tells me that he wanted to get into the Guinness Book of Records as the one who has donated the most organs. You know, so we have to be very, very careful about the psychological reasons for doing these things. When someone comes from abroad, my former chief, John Nigerian, was one of the pioneers with Tom Starzl in transplantation. And when I was a fellow, I remember we had a jet coming in from Saudi Arabia, some prince or whatever. So Dr. Nigerian sees him in clinic and says, and your donor is with you as well. And the guy looks up and says, I have many donors. You just choose the one, I mean, that's best suited for me. So that's another one of those things. We have to make absolutely sure that there is no financial interest in donating. Usually between siblings, parents, and so forth, that's different. But let's say someone works with someone. I mean, do we know that person is not in some way coerced, or are there any financial incentives involved in it? So, I mean, that's where the psychologist, the social worker, and the entire team comes in, because, I mean, this is immoral, basically, and it's illegal. So we have to make sure that living donation is clean as can be, because if it's not clean, I mean, the entire field of transplantation gets a bad press. So I already talked quite a bit. I think what I'll do is I'll stop here and later talk about the pancreas surgical issues, but I just want to give you a few perspectives of what I think what is important. The other thing is be proud of being involved in the transplant program, because it's more than surgery. It's also medicine. It's more than medicine because it's also surgery. You know, I mean, this is a field where you take care of patients with end-stage organ failure. Obviously, we're doing it right now for kidney transplant patients, but hopefully, I mean, in the future with heart and liver as well. And despite the fact that many things are standardized, you are exposed to many diseases I mean, hypertension, metabolic issues. You're dealing with some of the sickest patients in the hospital. Transplantation, from the surgical point of view, is the crown jewel of surgery. I mean, it is much more complicated than taking care of a patient with a hernia or appendix or even a bowel resection. I mean, you all know that. So I think, I mean, there's something about transplantation that makes us all proud. I'll stop here, and then I think our next speaker is Dr. Tiller. Okay.
Dr. Kerber, I think you know if you're going to be here.
I think you have your mic. You have a mic.
Oh, I'll be back in line. I'm so sorry. I'll be back in line.
I just need to make that call and I'll be there.
Okay. Sorry.
I think everybody got up to get their coffee, so give us just 2 seconds.